Hey, going live today to talk about sensory discrimination assessment. And this is an amazing tool that PTs, OTs can use to really dive in to what is the underlying sensory issue for a person with pain, with dystonia, with functional neurologic disorders, and so many more things. So, by the way, if we haven't met, my name is Julie Hirschberg. I'm a neurologic physical therapist, and I'm the owner and founder of Reactive Therapy and Wellness. I'm in the Los Angeles area, and love to join you every week to talk about what I'm reading, what we're learning, what we're doing. And this particular article is something that it's from 2019, so not as new, but something that has really gotten me excited about how we might do sensory assessment. And if you're a clinician, we recently created a brand new resource for you all about sensory assessment. And this test that I'm going to show you is actually in it. And the training that comes alongside of it is from this article. So let me give you the name of the article, which, by the way, I'll put in our newsletter this week. This article is called A Central Nervous System Focused Treatment Approach for People with Frozen Shoulder, Protocol for a Randomized Clinical Trial. And you might be saying, but you don't really even treat frozen shoulder, Julia. And I'd be like, you're right. I maybe have like a couple times in my whole career. So that's not the point. The point is not frozen shoulder. The point is taking a central nervous system approach to sensory training. And this is the first place I ever saw that there was a protocol. And then they went on and tested this in people with frozen shoulder. And I got to tell you, the reason I heard about this, because there was a great talk at a physical therapy conference, CSM, and maybe it was in 2019 also, where it was Adrian Lau, and it was called The Frozen Shoulder Has a Brain. And I was like, oh, yes, it does, because every part of our body is controlled by our brain. But what the purpose of this talk was really to talk about how some of these chronic and really painful conditions are really being driven by the brain. And so we have to treat the brain and not just treat peripherally. Somebody is asking, Spunky Judy, hi Spunky Judy, is asking how to get on that list. So in my post today, if you go to the Reactive page on Instagram, I posted a picture of the study that I'm talking about today and of this topic, and you can actually comment on that post newsletter, and I will send you a link to our newsletters. We have a patient newsletter at reactivept.com and a clinician newsletter at reactiveeducation.com. So again, this article was published in 2019. It is in the journal Trials, and it was a publication of the protocol. And I actually brought Tigger again to show you this. So by the way, if you're a clinician, you can download our freebie at reactiveeducation.com/sensory. And we actually go through a step-by-step of how to do the testing part of this. But then after you test it, what do you do? What do you do to treat it, right? So I'm going to show you what they did on this protocol. But first, I want to show you Tigger's back and this grid. And I shared a video earlier this week with our team that our team took where when somebody is having symptoms in a particular area, you want to test out if the sensory system is involved. You want to look at what's the map look like? What's their sensory map look like? So every person, Tigger included, has a part of their sensory cortex in their brain that has a whole map of their body. And in some conditions, that map might get distorted. Pain, dystonia, functional neurologic disorders, CRPS, even concussion, sometimes that map can get distorted. So we want to test what that map is. So one way to do this is sensory discrimination testing, where we actually create a grid. We call this the 9 grid because we've got nine spots on here. And so if it was Tigger's back, let's say he was getting trunk dystonia. So Tigger's back, I would put the grid on. And it doesn't physically have to be on there. So you could take a picture of the back and then draw it on the screen. So draw it on label 1, 2, 3, 4, 5, 6, 7, 8, 9. And then I give Tigger, I can't give him my phone because I'm on my phone giving this talk, but I give Tigger the picture of it. And then I would ask Tigger, where am I touching you? Oh, that's 1. Oh, I can't tell. Oh, I can't tell. I can't tell there either. Oh, that's 2. So I might discover there's an area where he has a good map and an area maybe that he doesn't. And then we will actually do training. Tigger, this is 1. This is 2. This is 3. And so on. I know that sounds maybe a little boring. So you can certainly make it more exciting. And that's actually what's in this protocol when it comes to treatment. So I got to tell you, one thing I did after reading this article is I made a step-by-step of this protocol for myself because I wanted to be able to do this with people. And so when we do this to train, so let's say somebody has an impairment, they have a distorted map, they can't sense or identify between 2 areas, then we're going to train it. And we might start with, and in this protocol, they actually start with visual input and say, this is 1, this is 2. It's hard to get better at this without actually having some feedback. This is for the person that can't really discriminate it at all when you're testing it. So you actually identify and give them the visual and verbal feedback about it. Then you take away that feedback, right? So that's how a person gets better. So this is considered stage 1. So in this protocol, this is typically 1 to 2 weeks, but I'll tell you, I've had folks where they were good at this part. We needed to progress to something else. So that's what I like about this protocol. Each of the stages you could test and start there so that you're starting at the right spot for the person. So you're randomly touching a spot. First, you're doing it with visual and verbal input, and then you're taking away that input. One thing I also do if somebody is really impaired, I might just start with one line, or one horizontal line, and then keep gradually building that out. Because remember, some of our same principles of motor control apply, is that we want to challenge somebody, but they need some success too. So that is stage 1. So they even have in the protocol that you would start, and I'm reading this in, 1 block of 60 seconds and then a 3-minute break. I love that. Very nice. And then you would provide 5 to 15 seconds of rest between each stimuli. So it gives them a chance to reset. And then you would progress to the next stage when they are 80% accurate with that initial, just touching the basic 9 grid. This is all in the article, by the way. The article is free full text. I'll include it in our newsletter. I'll go on to stage 2 here, but I did see a question. So Cass, for an F&D client presenting with mildly reduced sensation in one upper limb, is there a standardized way to map the arm for equivalent discrimination? Yes, we can map the arm. So what I would do, so I will tell you, and we have this in our free resource. So I'm going to actually take off Tigger's grid here. And let's actually put it on his arm. So we know that some of the receptive fields for the body are different based on different body parts. So the face and the fingers have really close receptive fields. We would make a smaller grid, and other parts of the body have large receptive fields, and we make a bigger grid. But I will tell you, even though there's norms for this of how closely a person might be able to discriminate between 1 touch or 2 touch, I do this specific to the person, because a person with F&D, they don't fit the norms anyhow. So I usually start with a larger grid, and then I might make it smaller and smaller. So It's not as pretty of a grid on Tigger's arm, but we would do the same thing. Now, a word of caution that I found in some disorders. This is a lot of attention to the limb. And if a person, so let me say, this can be very helpful for a person that actually lacks some sensory awareness and lacks some even interoception. This is not helpful for the person where paying attention more to the sensation on their skin increases their symptoms. So, and I think that's really clear because you'll go to do this test and they'll be worse and then you'll stop. That's not a great test for them. Now, the test is fine because it gives you some information, but I wouldn't go into training with this much attentional focus. So if I find that this is worsening symptoms, I'm going to move to sensory training that is more externally focused. And that's fine. People are different. People respond differently. So really great question about that. So we start with the 9 grade and just touch. Now in stage 2 through 4, and these are like week 2 through 4, and again, I've done them faster, I've done them slower for people. Now we are taking 2 different stimuli. So this is not only sensory discrimination for the localization, but now can you sense 2 different things? So I think they actually recommend a pen cap and a cork. I don't always have those things, but I often have a pencil. So I might use an eraser for one, and then maybe I use the tip of the pencil for another. So now they're saying, oh, that's 1 and it's the top of the pencil. Oh, that is 9 and it's the eraser. 2 different modalities, right? I will tell you again where I've done this and didn't even realize how cognitively taxing this was. This is a lot of attention, and that also can make symptoms worse for a person, right? So keep in mind the cognitive energy a person has for this task as well. So now we go through and we're going to progress until they can do this 80%. Then we're going to progress from 9 grid to 12 grid. So we add another line. So now we're adding more discriminatory capacity to it. That's stage 2. Stage 3 is, I think, where it gets really fun. And now we're doing graphesthesia. Graphesthesia is, let me sit down, Tigger, for a second. I don't have a very big desk. So let me put him down there. So graphesthesia is your ability to recognize letters or numbers when they've been drawn on you. I know that doesn't seem very functional. That doesn't happen a lot, but it tells us some of the integrative components of the sensory system for a person. So it's a sensory perceptual task, an integrative task for the sensory system. So we take this 9 grid, but now we're looking at letters and numbers on that same area of the body. I find this is a lot more fun than just the 9 grid. And what you do, what they did in this protocol, which is a lot, I don't always do this many. They do 3 rounds of 60 letters. They start with uppercase, and then they progress. They progress the size of the letters, make them smaller. So the larger the letter or number, the more of the receptive field that you're getting. So the smaller, the harder. Then they alter the orientation of the letters or numbers and the speed of the letters or number. Faster is harder. And so technically, this is one of the skills that I used to be in charge of teaching all the PT students. And technically what you want to do is be continuous. So you have to think of letters like C and D and G and J, L, M, N, W, U, Z, so that you don't pick up your finger. So it should be a continuous letter. It's funny, whenever I do this, I have a brain fart and I can't even think of letters that are continuous. So I literally write them down on my little cheat sheet of all the continuous letters and numbers that you can draw. So graphesthesia is weeks 4 to 6, and you're doing this in the area. So for the person who asked about doing this in F&D, you might try the grid and see if that brings too much attention to the area. And if it does, I might go straight to graphesthesia, or I might go to the discrimination one, because it's a little more externally focused, not just like, where am I touching you? It's like, what is touching you? So I like the external focus of these stage 2 and stage 3. Stage 4 is the second part of graphesthesia. So in stage 4, this really gets really fun. Now you're doing a 3-letter word on the body. And so here again, you would generate a list of words. The protocol is 60 3-letter words. And the protocol is to start with uppercase letters and then move to lowercase, decrease the size, alter the orientation of the letters, alter the speed of the letters. That's how you would progress over a couple of weeks. And again, it was really hard for me to think on the fly of all of the words that I could write without taking my finger off 3-letter words. So I have this list of words: all and any, are, bad, bet, big, boy, box. Anyway, have a whole list so that I could have a continuous words without picking my finger up. So that is graphesthesia part 2. And again, depending on your patient, you may end up starting there if the other pieces are fine. And then there's stage 5. So this is the final. And in this one, you're writing the word, but the letters are overlapping, meaning instead of writing it out like C-A-T, you would write C and then A and T over the top of it. A lot more difficult to sense. And when we're talking about the sensory map, that requires a lot of sensory discrimination. Super helpful if your sensory map is distorted. You want to improve sensory discrimination. And then it's fun. It's fun. Now, what I'll tell you, so again, this was the protocol of the study. Let me say the study name again: Central Nervous System Focused Treatment Approach for People with Frozen Shoulder. This was a protocol for a randomized controlled trial. And they created this because they did a very small study, and people with frozen shoulder got better with just 3 sessions of sensory training, which had really just not been done in frozen shoulder, and is pretty incredible. So that's kind of the why they created this. They did. Now, I have not seen the big randomized controlled trial come out. I have seen that they published a feasibility study, so a smaller study looking at this, and these people did a 10-week intervention where they did this and graded motor imagery. They practiced at home, and people improved. But it was by a very small amount. It wasn't an earth-shattering study by any means. But one of the things I have found by doing this clinically is that it's hard to do at home. You have to have somebody do it to you. And if you don't have somebody that has the patience to do the grid and draw, the letters and all of the things, it's really hard. So I've spent time kind of brainstorming and trying other things with folks. And one of my favorites is actually using stamps. So if you get a whole bunch of stamps, particularly the ones for kids that are kind of big and thick, and they have ridges on them with distinct shapes, you can then, as the patient yourself, actually stamp it on yourself and try to recognize it. You can't draw on yourself. You can't touch yourself and try to recognize it, because touch from yourself is an entirely different touch. But you can try some things with stamps. So I have been loving stamps for sensory discrimination training when a person does not have somebody to do it. for them. And then also some of the things that a lot of our team will do are different buckets of small items that a person might have to discriminate in their hands. Now, this is something called stereognosis, so the ability to detect objects by manipulating them in your hands. And then you would do this with like a bucket of rice and different items in there, and you could do it with your eyes closed and try to identify objects. So that would be another way somebody could do self-sensory discrimination training. But I was so stoked when this article came out to see a protocol of how to progress this. I've used it. I think it can be very helpful for certain people, but particularly in CRPS, in pain, dystonia, functional neurologic disorders. So I'm curious your thoughts. Give it a try. If you're a clinician, go download our sensory resource. It's called our I'll get the name right. It's like Beyond the Basics Sensory Assessment Pocket Guide. So it's just a few pages and it goes through sensory discrimination training. It goes through the 9 grid that we did with Tigger today. And it goes through a couple of more and how and why you would use these. As a clinician, I am only as good as my assessment. And if I don't have a really clear and thorough assessment, I don't know where to go for a person. And I don't know if they're getting better either. So the sensory assessment guide is your place to get started. And especially if you've tried a lot of other things, but haven't really kind of hopped into the sensory world, it's a great place to start. So again, if you're a clinician, go download it. It's at reactiveeducation.com/sensory. And I will share this video and these articles with you all this week in our newsletter. You can join that if you're a patient at reactivept.com, and if you're a clinician at reactiveeducation.com, and I'll send it your way. But once again, thank you so much for your wonderful questions and for just really what you're doing for your amazing patients. And I'm just excited that now you're going to do a little more sensory testing and training, just like we did on Tigger here. So thanks so much. Have a wonderful evening, and we'll see you again soon.